Good afternoon, everyone. I call this meeting to order. Welcome to meeting number 18 of the House of Commons Standing Committee on Health. Today we meet for 1 hour to hear from witnesses on our study of Canada's health workforce, followed by 1 hour in camera for drafting instructions. Before I introduce today's witnesses, a few reminders for hybrid meetings. Today's meeting is taking place in a hybrid format pursuant to the House Order of November 25th, 2021, per the directive of the Board of Internal Economy of March 10th, 2022. All those attending the meeting in person must wear a mask except for members who are at their place during proceedings. For the benefit of our witnesses, first of all, thank you for your patience. Once we commence, I would ask that you wait until recognized before speaking. You are, of course, participating by video conference. You click on the microphone icon to activate your mic, and I would ask you to mute yourself when not speaking. At the bottom of your screen, you have something there for interpretation. You have the choice between floor, English, or French. And a reminder that all comments should be addressed through the chair, and please don't take screenshots. The proceedings of today's meeting will be made available through the House of Commons website. In accordance with our routine motion, I'm informing the committee that all witnesses have completed the required connection tests in advance of the meeting, and we will now welcome our witnesses who have patiently awaited the commencement of today's meeting. We have from the Association of Faculties of Medicine of Canada, Dr. Geneviève Moineau, President and Chief Executive Officer. From the Canadian Health Workforce Network, Ivy Lynn Bourgeau, Director. From Pallium Canada, Jeffrey Moat, CEO, and Dr. Jose Pereira, Scientific Officer. And from the Federation of Medical Regulatory Authorities of Canada, Fleur-Ange Lefebvre, Executive Director and CEO. Thanks to all of you for your patience. Thank you for your presence. We will begin with opening remarks in the order in which the witnesses appear on the notice of meeting. Even though we've tested your indulgence with our late start, I would ask you to please try to respect the 5-minute timeline. There is a possibility that today's meeting is going to be condensed, and we'll want to make sure that we do have time for questions and that everyone has time to get their statements in. So opening statements will be 5 minutes. We're going to start with Dr. Moineau. Welcome to the committee. You have the floor.
Thank you, Mr. Chair. Can you hear me well?
Yes, loud and clear.
You. Honorable members of the Standing Committee on Health, thank you for inviting me to speak today on behalf of the Association of Faculties of Medicine of Canada. I'll be speaking in English, but be pleased to respond to any questions in both official languages. I have the pleasure of joining you today from the beautiful Lake Louise, Alberta, Treaty 7 territory, the traditional and ancestral territories of the Stoney Nakoda Nations, the nations of Blackfoot Confederacy, the Dene people, and the Métis Nation of Alberta, Region 3. The AFMC is located in Ottawa, the unceded, unsurrendered traditional territory of the Anishinaabe Algonquin Nation. My name is Geneviève Moineau. I am President and CEO of the AFMC. I also practice pediatric emergency medicine at the Children's Hospital of Eastern Ontario, and I am professor in the Department of Pediatrics and Emergency Medicine at the University of Ottawa. The AFMC represents Canada's 17 faculties of medicine who train and produce the physicians in this country. The AFMC commends the Standing Committee for this study on Canada's health workforce. We recognize that solutions around human health resource planning need to include considerations of all health professions. The ultimate goal is that patients receive the right care by the right care provider at the right time. AFMC is committed to serving the needs of Canadians and has been a long-time advocate for better physician resource planning in Canada. I believe we have valuable information to share with you today in support of this important study. As you have heard from past witnesses, the 2019 Canada Community Health Survey found that approximately 4.6 million Canadians aged 12 and older reported not having a regular healthcare provider. The pandemic has exacerbated this long-standing deficit. We encourage the federal government to help coordinate change and inspire provincial and territorial leaders to ensure that we have the right number, mix, and distribution of physicians to meet societal needs. There are key considerations I would like to highlight based on the data the AFMC collects. First, current admissions to medical school are not aligned with population growth in Canada. Secondly, an increasing number of Canadian medical school graduates have a delay in their entry to residency and therefore a delay in providing the care Canadians need. Thirdly, we are currently not responding to the need for family physicians, particularly in rural settings. Medical school admissions should align to the population growth to meet societal needs. While the Canadian population has increased by 12% since 2010, admissions to our medical schools has only increased by 6%. Not only are admissions not increasing at the same rate as the Canadian population, but we continue to see Canadian medical students unable to secure a residency position on their year of graduation. For each medical graduate produced in Canada, public funds are expended. When these graduates go unmatched, there are delays to them entering practice and providing care to Canadians. Increasing the number of residency positions to ensure that there's at a minimum 110 residency positions for each 100 graduates will reduce the number of unmatched Canadian medical graduates. Federal and provincial leaders must work together to ensure that Canada has the right number of residency positions for the system and adequate flexibility to ensure the success of our learners. Additional family medicine residency positions should focus on the capacity for training in rural communities to further meet the urgent needs of Canadians. The AFMC recommends that the Government of Canada work with provincial and territorial governments to increase admissions to medical school to match population growth, and that all graduates of Canadian medical schools have access to residency positions upon graduation. Thank you for your time today, and I look forward to answering any questions you may have. Merci beaucoup.
Thank you very much, Dr. Monod. Next, we're going to hear from the Canadian Health Workforce Network. Ivy Lynn Bourgeot, you have the floor.
Thank you, Mr. Chair and committee members.
Merci, Monsieur le Président et les membres du comité. Merci de m'avoir invité à prendre la parole devant le comité sur la question de la main-d'œuvre en santé au Canada, qui revêt une importance cruciale. Je viens d'Ottawa, le territoire traditionnel non cédé et non rendu du peuple algonquin Anishinaabe, auquel je rends hommage. Je m'appelle Ivy Bourgeot.
Health Workforce Network, a pan-Canadian knowledge exchange network of researchers,
Ms. Bourgeot,
knowledge users.
Ms. Bourgeot, okay. We had a technical issue with the translation that was resolved in the time it took me to interrupt you, so please go ahead.
Would you like me to begin again?
Is everyone okay with her just to pick up where she left off, Mr. Garon? Okay. No, please go ahead from the point where I interrupted you, not from the top.
All right. My name is Ivy Bourgeot, and I'm speaking on behalf of the Canadian Health Workforce Network, a pan-Canadian knowledge exchange network of researchers, knowledge users, dedicated to bringing the best evidence to provide solutions to health workforce challenges. Let me begin plainly by stating that if Canada's health workforce was a patient, it would be in critical condition. It needs immediate attention. The committee has heard from many providing testimony to date that the pandemic has caused unprecedented burnout, distress, and record-level vacancies due to health and safety concerns, unsustainable workloads, canceled vacations, and forced redeployment. And then there's the violence. In this committee's 2019 report, you noted that health workers are 4 times as likely to face workplace violence than any other profession. yet most of it goes unreported due to a culture of acceptance. Recognizing that this requires action beyond this committee, we are still waiting for the recommended public awareness campaign and Pan-Canadian prevention framework. We are still waiting also for the much needed update to the Pan-Canadian Health Workforce Strategy to address staffing shortages, which this committee recognized exacerbates the violence health workers experience. COVID-19 has traumatized Canada's health workforce, but most of these challenges predate the pandemic. The pandemic has sharply exposed the lack of clear answers to the most basic questions about Canada's health workforce. For example, we know little about how many health providers work in critical sectors such as home care, long-term care, and mental health care. Canada lags well behind comparable OECD countries in terms of health workforce data and decision-making tools. Health workforce research receives less than 3% of health services and policy research funds and less than 1% of all national health research funds. Other OECD countries provide nationwide support for evidence-based decisions, but here in Canada, we are left to make critical decisions in the dark. This lack of very basic human resources knowledge is particularly egregious because health workers account for more than 10% of all employed Canadians and over 2/3 of healthcare spending in Canada, which amounted to $175 billion in 2019, or nearly 8% of Canada's total GDP. Recognizing these facts, all levels of government, including the federal government, play an essential role in sound policy development, strategic health workforce planning, and health system stewardship. To date, more than 65 healthcare organizations and 300 health workforce experts and organizational leaders have signed on to a call to action for the federal government to take a lead in supporting provinces, territories, regions, hospitals, health authorities, and training programs in investing in better health workforce data and decision-making tools. In our brief to the committee, we put forward a set of promising evidence-informed solutions for consideration. Our preferred option, based on existing Canadian models and leading international practices, is for the federal government to create a dedicated, coordinating health workforce agency with a mandate to enhance existing data infrastructure and decision support tools for strategic planning, policy, and management across Canada. This would be akin to how the Public Health Agency of Canada was created after our last SARS crisis, a crisis dwarfed by COVID-19. In addition to addressing needed data and decision-making infrastructure, an agency could address the immediate challenges by gathering and sharing leading evidence-informed practices to retain health workers and foster the return of those who recently left, while also informing Canadian-focused recruitment strategies, the new 3 R's of health workforce management: retain, return, and recruit. Those working in healthcare today need to know that a better future lies ahead. They are tired and the great resignation looms large. Patients in critical condition require follow-up care, ongoing monitoring and support, and measures to prevent critical illness from happening again. This is exactly what we need for the health workforce. The public understands this. Overall, 9 out of 10 Canadians in a public opinion poll from this past March say that they are concerned about the mental health of healthcare workers. 8 out of 10 are also concerned about what this means for their access to and the quality of healthcare. Action is needed now. The status quo must be seen for what it is, the most expensive and least tenable option going forward. I'd be pleased to address any of these or other points with the committee. Thank you again for this opportunity.
Thank you, Ms. Bourgeau. Next, we're going to hear from Pallium Canada, Jeffrey Moat, CEO. Mr. Moat, you have the floor.
Thank you, Mr. Chair, and to this committee for this opportunity to speak with you today. I'll be joined by Dr. Jose Pereira in sharing our remarks with you. I am the Chief Executive Officer of Pallium Canada. I want to take this opportunity to acknowledge the land in which I'm presenting from, the City of Ottawa, is the traditional unceded and unsurrendered territory of the Algonquin and Anishinaabe people. So for over 20 years, Pallium Canada, a national nonprofit organization that was established in Alberta and is now has its head office here in Ottawa, has been equipping frontline healthcare workers with the essential skills needed to provide palliative care to Canadians. The ability to provide a palliative care approach when and where it is needed is essential for all health human resources. In a modern, agile, and increasingly diverse workforce, yet most healthcare professionals receive little to no training in palliative care during their formal health education. Pallium's flexible and adaptable interprofessional training solutions meet both the team and individual learning needs of all healthcare professionals, including physicians, nurses, social workers, personal support workers, paramedics, and others. Pallium has developed training specifically targeted to healthcare leaders so that they have the knowledge necessary to support the success of the healthcare teams that they lead. Pallium's LEAP programs. LEAP is an acronym, by the way, for Learning Essential Approaches to Palliative Care. And these have been proven to increase palliative care knowledge and skills and empower healthcare providers to make changes in their practice and improve the palliative care that they provide to patients. The interprofessional design of LEAP courses also creates a common understanding and culture among healthcare teams and has been shown to increase job satisfaction and enjoyment. As a national evidence-based accredited training program, LEAP supports health human resource labor mobility and responds to identified workforce mental health needs. And this is something that was recently highlighted in Ontario's long-term care staffing study, which identifies the ability to provide palliative care as a key challenge for long-term care staff that negatively impacts their mental health and well-being. This lack of palliative care skills among health human resources in Canada has too often led to unnecessary pain and suffering for Canadians and grief for their family and loved ones who can't access the palliative care that they need. And if the pandemic hasn't made a strong enough case of the need for better skills training in palliative care, then I'm not sure what will. Past calls to improve these essential skills have been too often ignored. The good news is that solutions such as LEAP programming have already been paid for by Canadian taxpayers, but there needs to be a commitment to spread and scale such solutions so that health human resources have the competencies and confidence to provide better palliative care to more Canadians. Dr. Pereira.
Thank you very much. Honourable members, good afternoon, and thank you for the opportunity to make the case for health workforce preparedness in palliative and end-of-life care. I'm Dr. Jose Pereira, and I've been a palliative care physician, educator, and researcher in Canada for over 25 years, and I'm currently Professor and Director of the Division of Palliative Care in the Department of Family Medicine at McMaster University, and I'm also Scientific Officer and Co-founder of Pallium Canada. Advanced progressive cancer and non-cancer illnesses continue to exact a very high toll on Canadians in terms of quality of life, suffering, and healthcare costs. A large body of evidence shows that palliative care can reduce this burden by improving quality of life, reducing hospital admissions and emergency room visits, and reducing healthcare costs. While there have been noteworthy improvements over the last 2 decades with respect to access to palliative care services, and the integration of palliative care in the curricula of health professionals, many gaps remain. Despite what some may say, not all Canadians have access to timely, high-quality palliative care when they need it. One of the main reasons for this is the lack of health workforce preparedness to provide palliative care. These workforce issues relate to both specialist-level palliative care and to primary, or also known as generalist-level palliative care. If equipped with core palliative care competencies, clinicians and other professionals across many fields such as primary care, long-term care, cancer care, cardiology, and nephrology, to name just a few, are also able to initiate a palliative care approach. There are currently not enough palliative care specialists and funded positions for palliative care clinicians in many Canadian jurisdictions. Moreover, many palliative care clinicians, including myself, are nearing or contemplating retirement. In a study that I co-authored in 2015, we found only 265 physicians in Ontario who practice mainly palliative care. Emerging standards call for at least double that number. There are not enough funded training positions for palliative care physicians. In my own division of palliative care at McMaster University, for example, we have the capacity to train up to 6 or new palliative care specialists every year, but receive funding for only 1 trainee a year. In my clinical work, I often see palliative care being activated only in the last days or even hours of life when it's too late. This is demoralizing when there is evidence and experience to support early palliative care initiated many months before that, alongside treatments to control the diseases. And a root cause, again, is lack of core palliative care knowledge and competencies across the health workforce. In a large 2015 study involving primary care professionals across several OECD countries, only 42% of Canadian primary care doctors said that their practices were prepared to provide primary palliative care to their own patients, largely related to lack of education or experience. And this is one of the lowest rates across the 10 countries studied. And it's not only in primary care, we see similar findings across studies across different specialty areas. In a recent Canadian study, palliative care clinical rotations were mandatory in only 2 medical schools, not offered at all in 2, and only optional in 13. And at the postgraduate level, only 60% of family medicine trainees and only 31% of internal medicine residents completed such rotations. The good news is there is evidence that core training can make a difference. In a large study that we did involving over 4,000 doctors, nurses, social workers, and pharmacists who completed Pallium Canada's LEAP courses, we found that these courses improved advanced care planning and goals of care discussions, improved pain and symptom management, improved opioid use, and improved teamwork up to 4 months after the courses. We look forward to a future where these workforce training needs are addressed and long-term investments are made in palliative care training to increase specialist level and generalist level palliative care in Canada, and to spread and scale up across all care settings, existing proven Canadian-made education programs. Thank you very, very much.
Thank you, Dr. Pereira and Mr. Moat. And next, we're going to go to Ms. Lefebvre, please.
Good afternoon, Mr. Chair and committee members. I thank you for the opportunity to appear before you today. I also have the privilege of speaking to you from the same Indigenous lands as those who spoke before me this afternoon. I want to highlight a few things before I start. A, I am not a physician. B, the Federation of Medical Regulatory Authorities of Canada's members have delegated statutory authority to regulate physicians to serve the public interest. And C is a voluntary member-based organization representing all 13 provincial and territorial medical regulatory authorities, or MRAs. FEMRAC facilitates discussion and collaborative efforts of its members towards a goal of improved regulation. HESA has undertaken this study in recognition of the exhaustion and burnout among healthcare providers, including physicians. Over the last few years, the MRAs have seen an increase in the number of physicians who have come to their attention because of burnout, mental health, and substance abuse disorders. Now, MRAs are mandated to protect the public, and their responsibilities rarely, if ever, include advocacy for the profession. However, they do include administration of a quality assurance program for identified physicians. While this is hard to quantify, FEMRAC believes the exhaustion and burnout of physicians across Canada are significant enough that they are having a negative impact on the quality of care that Canadians are receiving. In other words, physician health is a patient safety issue. Your study intends to examine how the federal government can facilitate the recruitment and retention of healthcare professionals. The only way to do this is to approach the situation by putting the patient smack in the middle of this discussion. I'm going to address 4 issues. Firstly, virtual care. FEMRAC defines virtual care as the provision of care by means of electronic communication where the patient and the physician are at different locations. MRAs believe virtual care may enable more access to care across Canada. However, physicians are expected to provide all elements of good medical care. The standard of care expected is the same whether the patient is seen in person or by virtual means. Importantly, meeting the standard of care inevitably requires access to in-person care for many conditions. This means that virtual care can only be leveraged so far. Secondly, international medical graduates, or IMGs. IMGs seek to come to Canada from many countries with very many different training programs. Supporting pathways to licensure for IMGs is a meaningful opportunity to help address health human resource shortages, provided the right review and assessment protocols are established and or maintained. Graduates of Canadian medical schools, as Dr. Monu can very well describe, go through thorough accredited undergraduate and postgraduate training with regular assessments along the way before being promoted to the next level of education. They also must pass national certification exams before being issued a license to practice in any part of Canada. These are all steps along the way to ensuring the public that the physicians who treat them are qualified to do so. MRAs also have mechanisms in place to study the international graduates, to assess the international graduates. However, there are limited resources available, and to scale these programs up to a broader national level would require a lot more resources, but that would make a significant impact possibly on the challenges Canada is facing today. It would, in our opinion, be unconscionable to bypass the appropriate review and assessment of each IMG candidate on the route to licensure simply to increase the number of physicians available, because even a handful of incompetent physicians can have a dramatically negative impact on the health and safety of tens of thousands of Canadians. Thirdly, a national registry of physicians and other healthcare providers. The MRAs are the single source of truth when it comes to data about physicians who are licensed to practice in this country. Their data are held in each province and territory. Having a national registry or list of all the physicians could be a very useful tool for the regulators themselves, as many healthcare workers are licensed in more than one jurisdiction, but also for health human resources planning, especially if those data include information about the practitioner's scope of activities. Such a registry requires significant developmental resources and an ongoing commitment to maintain the database up to date and relevant to governments, regulators, researchers, and policymakers. Two important tools are already available for medicine: a unique identifier for universal data collection and a common portal for licensure applications. In addition to a national registry, the federal government may wish to look at the U.S. National Practitioner Database. I have more information about that in the document I submitted. And finally, other healthcare providers. FEMRAC and the MRAs welcome other regulated healthcare professionals like physician assistants, nurse practitioners, anesthesia assistants, associate physicians, and others into the system because they can assist in meeting the healthcare needs of the people of Canada. For all healthcare professionals, the main tenets will be the identification of the required competencies, the appropriate training to achieve those competencies, and finally, the relevant assessments in the right settings to ensure those competencies have indeed been achieved. In closing, thank you for allowing me to present to HESA today. I am happy to answer your questions and listen to your comments in both English and en français. Thank you.
Thank you very much, Ms. Lefebvre. And we're now going to begin with questions, starting with the Conservatives. Mr. Barrett?
Thank you very much, Chair. Thank the witnesses for joining us today. Chair, I just have one item of business that I'd like to do before handing my time over to Dr. Ellis. And I'm seeking the unanimous consent of the committee through you that the following motion be adopted: that the Standing Committee on Health report to the House that it supports the full participation of Taiwan in the World Health Assembly and the World Health Organization. And as the notice wasn't provided 48 hours, it requires the unanimous consent of the committee, Mr. Chair.
Thank you very much, Mr. Barrett. And as you pointed out, the requisite notice wasn't provided, but that can be waived with the unanimous consent of the committee. So I think we have two questions. First of all, is the committee prepared to entertain the motion absent the required 48 hours notice? Do we have agreement on that? Yes. We do. And so now you've heard the motion. Is it the will of the committee to adopt the motion, or will there be debate? The motion is adopted by consent. Go ahead, Mr. Barrett.
Thank you, Chair. With a minute and 12 seconds used, I'd like to turn my time over to Dr. Ellis. Thank you.
Dr. Ellis.
Thank you, Mr. Chair, and thank you, Mr. Barrett. You're very kind. I'll jump right in it since we're already running significantly behind. I think that's the most germane thing. I would like to start with Dr. Moineau, if I could. We talked about kind of pairing admissions to medical school and residency spots together, trying to keep up with the growth in the Canadian population. We've known that we've fallen significantly behind. Does your association have, in real numbers, any idea of how many extra medical students we would need at the current time to make up the difference, and then what that might look like going forward from now forward?
Thank you for the question. We are in the process of confirming what those numbers are, as well as what the capacity is of our 17 medical schools at the present time. And so we would certainly be able to provide you this information in very short order.
Thanks, Dr. Monod. In short order, I've come from the medical field. That might mean 5 minutes. In the federal government, it might mean 15 years. But what's it mean in your world, if I could push you on that a bit? Sorry, I couldn't hear you at all.
Within the very next few weeks.
Okay, well, that's terrific. A follow-on question to that, and thanks for providing it to the committee here. Follow-on question to that, will that include data of matching medical schools with residencies, and can you speak to that of what the gap is at the current time? That seems to be a significant problem.
Thank you very much. We are currently midway through the match for this year, but we know that there is a gap of at least 100 positions at the moment, and that's without any increases in the number of medical school positions. And so we could certainly again provide you with an accurate number based on the match that's underway right now, which will be completed by the end of May. And so again, we could add that information to a subsequent package forwarded to the Standing Committee.
Great, thanks, Dr. Monod. And just to be clear for perhaps those people that don't understand the system, that means that there's 100 medical schools trained here, 100 medical students trained in Canada who now cannot become physicians because they don't have any position as a resident.
Upon year of graduation, that's correct.
And do we have any idea of how many of those types of individuals, I'll use that terminology, are kind of in Canada now, perhaps have given up on the match? Is that kind of data available?
So we know these are graduates of Canadian medical schools, and so they are in Canada. The issue is that there's a wastage of time in them not graduating and moving on to residency on that year. And so many of them eventually match, but even just to have to delay that by a year is really very unfortunate, both for the healthcare system, because we want those individuals to be able to finish their training and to become independent practitioners, but also is very detrimental for those trainees as well.
Yeah, understood, and thanks for that. Is there any idea of how many of those individuals have never been matched? Is there 50 of them? Or is there 1,000 of them over the years? Is there 100 a year over the last 10 years?
Oh, there would definitely be more than 50 over the last several years. But again, that information is a little bit harder to obtain, but we could certainly give you a range if that would be helpful to you.
That's great. Thanks, Dr. Monod. I appreciate it. I have a question for the palliative care group, Pallium, if I could. It's interesting, palliative care certainly is an institution, as a family doctor, that's near and dear to my heart, and certainly germane in terms of things like MAID, et cetera. There was a commitment of about $6 billion in funding over 10 years in budget 2017. Can you talk more how much money of that has organizations like Pallium received, and what's the difficulty in deploying that money and educating people around palliative care?
Yeah, thank you, Dr. Ellis, for that question. And the short answer to your question is very little. We've actually done some homework to understand just how much of this investment has been spent on palliative care. And according to the Office of the Parliamentary Budget Officer, the officer was asked to identify federal investments in palliative care made since Canada had legalized medical assistance in dying. And in December 2020, this is what was shared. As we know, based on a common set of principles on shared health priorities, the federal government subsequently signed bilateral funding agreements with each province and territory, and each province and territory developed an action plan that's usually appended to the bilateral agreement that specified how the federal transfers would be used. However, only 6 provinces identified initiatives specific to palliative care: BC, Alberta, Saskatchewan, Manitoba, New Brunswick, and Newfoundland. And according to the provinces' bilateral agreements, the total funding for palliative care initiatives for these 6 provinces was estimated at $170 million, and that's to the end of 2021, 2022. But we're not given any details on how these funds were spent. Unfortunately, the specific amounts allocated to palliative care are not available for the remaining provinces and territories because health is a provincial jurisdiction. As we know, Health Canada doesn't have access to or the authority to request program-specific accounting. So the long and the short of it, Dr. Ellis, is that we simply don't know how much and how exactly this money has been spent, which is disappointing. Dr. Prairie, would you like to add anything to that?
It was interesting because
very briefly, Dr. Pereira, we're well past time, so please be succinct.
Thank you. We visited about 8 provinces and territories in 2019 and early 2020. And the response was always, it's important, it's part of our strategic plan, but we don't have funding to support it.
Thank you. Thank you, Dr. Ellis. Next, Dr. Pawlowski, please, for 6 minutes.
Hi, so we're here to examine the healthcare workforce shortage and what we can do about it. Now, as somebody who graduated from medical school in 1986, I've been doing this a long time, and you know what? Nothing's changed. We had a shortage of people, particularly in underserviced areas 35 years ago. We still have that shortage. The answer has always seemed clearly to me in front of our noses: foreign graduates. There have always been a lot of foreign graduates in Canada. I've certainly known enough of them in my time who find it very hard to get licensed in Canada. And so there's been this mismatch. There's been a need and there's been a desire of foreign trained doctors to work in underserviced areas. What is the problem? I think I've asked this to a few people here. I'm not sure what the problem is. Certainly, I have some suspicion that it's medical protectionism, that organizations like the CMA, the OMA, are dominated by doctors from big cities. And when you work in a big city, which I've done a little bit, I've done far more work in underserviced areas, but in big cities, you know, you want patients. I mean, you're competing for patients. You want to maintain your salary. So I somewhat suspect the problem is doctors not wanting to make it easy to license foreign trained doctors. The other possibility is that the provinces realize more billing numbers equal higher healthcare costs. So I throw that out there as two possibilities. I wanted to ask Ms. Lefebvre from what's the organization? The Federal Regulatory Authority, as to her views on this matter. What has been the barrier to licensing more foreign graduates?
Thank you for that question, which I knew was coming. So this is good. I've been asked this several times before. So 2 things. First of all, I cannot speak on the payer's approach to this. Okay, so the regulatory authorities do not issue billing numbers. They issue a license to qualified physicians. IMGs, as I said, are come from all over the place, from very different training systems. Canadian graduates undergo really thorough assessments in real life, okay, like with patients in real live healthcare situations. So our approach to this is that an IMG, in order to come to Canada, for the most part, not all of them, but for the most part, has to undergo a similar kind of in-practice assessment. They are expensive to run, and it's a competitive process. So there are probably many more qualified IMGs than those who actually secure a spot for that. And once they've gone through that 12-week process, they would then get to do, they would get a provisional license under supervision, and there are steps to move them away from a provisional to a full unrestricted license. Now, you have had presentations from the CMA and the Royal College, and the Royal College is developing different mechanisms to hopefully get these people assessed a little bit faster. Medical education is a complex and very expensive system. So I think it's time that we might want to ramp this up. But in order to ramp it up, you must also have the capacity to do the assessments. And right now that's been quite challenging.
Okay, can I interrupt you there? So this is the first I've heard of this 12-week assessment. Yeah. Excuse my ignorance, but what is that? Is that all colleges of physicians and surgeons across Canada allow this option, or only some? How does this exactly work?
More than half of them do. It's called the Practice Ready Assessment, but it was designed primarily for physicians who would come into Canada to work either as general internists or as family physicians. In order to assess the specialist and the subspecialist physicians, you almost need a one-to-one, especially designed program for them. And that's again, quite a bit more challenging.
Do I get you right? There are not enough positions for these practice-ready assessments, so a lot of foreign graduates don't get to enter into the process to be evaluated?
That's correct. It is because of resources, it is a competitive process. And so we have way more applicants who would probably qualify if there was an unlimited number of assessment
Do you know
positions.
how many positions there are in Canada each year?
I could find that for you. I don't have it at the tip of my fingers, but it's relatively modest, but it depends on the jurisdiction. You know that over approximately 25%, I was going to say over, but I think I will stick to 25% of practicing physicians in Canada are international medical graduates. So many of them do get through.
And by modest, just give me a ballpark figure. Are we talking thousands, hundreds?
Hundreds.
Could get us that information. And if the federal government was to put more money into opening more practice-ready assessments, do you think that we would be able to do that rapidly in order to evaluate the skill of foreign-trained doctors and get a lot more people out there quickly?
It would be wonderful to be able to say yes to that, but because the other resources that it requires are human resources, so practicing physicians assessing incoming international medical graduates, I think there's that other side of the coin that would have to be factored into this, so it would involve some discussion. But I would be hopeful.
Thank you, Dr. Pawlowski. Ms. Lefebvre, suite Monsieur Garon.
Mr. Garon, you have 6 minutes. Thank you very much, Mr. Chairman. Thank you to all the witnesses for being here today. I'll start with a question for Dr. Moineau. Doctor, you eloquently explained that 4.6 million Canadians are having a hard time accessing a doctor or medical services in their community at this point. And this leads us to the issue of planning. How can we be in a better position to train doctors, send them out into the regions, into the hospitals? Of course, it will come as no surprise that the issue of funding is critical. This week, we heard from the Médecins Omnipraticiens du Québec, and they said that in order to improve practice conditions for the doctors to be available in the regions, there needed to be an immediate increase in transfers to the provinces, which used to represent about 35% of system costs and dropped down to 22% and then eventually 18%. Would this additional funding help for better long-term planning on the province's part? Thank you very much for your question. It's really not within the authority of the Association of Faculties of Medicine of Canada to really make comment on your question directly. But what I can say is that the way in which doctors are compensated for their work, for the care they provide, is really important when it comes to really meeting the needs of the populations they serve. I think it's important to think of the ways in which we compensate physicians, general practitioners, and I think it's really up to the provinces to really address some degree of unfairness in terms of how people get paid. Correct, I realize this is a provincial area, and I understand your answer, I understand your reluctance, but when general practitioners appeared, we really focused on the shortage of family doctors, and I think it affects the faculties. They were saying that family medicine wasn't valued enough in these faculties. It seemed as though it was hard to attract doctors into general practice rather than into other specialties. So that would require major changes in terms of technology, conditions of practice, facilitating the work that is done in the provinces, and a more predictable, long-standing type of funding would help the faculties going through the provinces to make these changes. What do you think of that? I agree with you. It is important for faculties of medicine to accept students who are prepared to be family doctors, primary care physicians, and general practitioners. This is an issue that we address in Quebec and other provinces. That's an important question because we know faculties are the ones that decide who enters the profession, who is accepted into medicine. So we need to make sure we accept individuals who are prepared to practice family medicine, general practice, and are willing to work in the regions. And now a short comment on the previous conversation. I would say this. We think it's important to invite young people in all of the provinces, people who live in the regions, to come get their medical education in a more regional way. We know that's helpful. It means that we can get more practicing physicians in the regions. We've done some work on this. There's still a great deal of work to be done, but this is certainly one of our future goals for faculties of medicine. Thank you very much. I have a quick question for Ms. Bourgeau. I read your brief, a very interesting brief. You're offering a number of solutions, but I noticed that some of your proposals really focus on a centralization of collection and information of health information at the federal level. You recall the Romano Commission, and this centralization was a major problem, specifically for Quebec to buy in. There were some delays, in a way, in the process of collecting information. I'm wondering if you would be open to a more decentralized approach that really respects the areas of jurisdictions of the provinces, but would allow for cooperation. For instance, a working group that would really give the provinces and Quebec some leeway.
Thank you for the question. I really appreciate that one. So it's important to kind of recognize what it is that we're proposing to be centralized, and that it is data to be standardized. So right now, the data that are collected, just even on the medical profession represented by my colleagues here, the data that are collected by medical regulatory authorities, which Madame Lefebvre has noted is excellent information, is not data that goes to the Canadian Institute of Health Information. The data that's collected by the Association of Faculties of Medicine of Canada, and it's extensive on medical students, also doesn't align with what data are collected by medical regulatory authorities and what goes into the Canadian Institute of Health Information. So the proposal is to have standardized data. An excellent way to standardize data would be to have a system of pan-Canadian registration. So this is really important that we are not suggesting that health workforce planning be undertaken at a national level. That's not an appropriate level for that to happen. What we are suggesting are that there would be standardized data collected in the same way that StatsCan collects standardized data, through the census on the population, and that the provinces and territories and regions and hospitals and medical institutions could actually do some planning. So right now, the data are siloed across jurisdiction, across organizations within a profession, and are siloed across the professions. And if we could just bring those together, that's what we're talking about, data infrastructure. Our conversation with folks in Quebec said they would very much welcome that, and a development of tools to help them to do much better planning at a local level, which is the most appropriate place. I hope that has answered your question.
Thank you, Ms. Bourgeau. Merci, Mr. Guerrero.
Thank you, Mr. Guerrero.
Davies, please, for 6 minutes.
Thank you, Mr. Chair, and thank you to the witnesses for your excellent testimony. Dr. Moineau, I'd like to start with you. In a 2018 article from University Affairs, you were quoted as saying this: "The deans have clearly identified the unmatched Canadian medical graduate as a top priority." You've already spoken to this a little bit, but I'm just wondering what the direction is since that was written 4 years ago. Has the number of Canadian medical graduates who are unsuccessful in matching to a residency requirement each year decreased or increased since that article was published?
Thank you for the question. And so as you identified, this was the recommendation that came out in 2018. And in fact, we did have a significant positive response to that, in that we had 3 provinces who actually changed their policy around how the match was structured that enabled a significant decrease in the number of unmatched. However, unfortunately, those numbers have started creeping up again. And the major issue that remains is that we do not have the appropriate buffer between the number of graduates of Canadian medical schools and the number of residency positions. We know that when we have at least a buffer of 10 positions, so again, for 100 graduates, that there's the opportunity for about 110 residency positions. And these are positions in all specialties, family medicine and all the other specialties, that allows actually to match just about everybody. You know, back in 2009, we had 11 unmatched Canadian graduates across the country. We're really hoping to be able to get back to those type of numbers and not the nearly 100 that we have now. So it really requires the provinces to be able to get to that ratio, and we're hoping that your committee and the federal government will support encouraging the provinces to get to that level of residency numbers in each jurisdiction.
Now, in terms of just graduates overall, which you've commented on, we know that Canada graduated about 7.5 medical students per 100,000 in 2020, and that was in the bottom 5 of OECD countries. I believe there's 38 OECD countries, so we're not doing well internationally. What advice would you give this committee about how we can increase the number of seats in medical schools?
So again, we would seek your support in encouraging provinces to increase their numbers, both of medical school spots, positions for students, as well as residency positions. You have to align those, and as I say, we suggest that alignment of 1 to 1.1. There are some provinces that have made some announcements already that are in the right direction, but we really need to see this across all provinces that currently house medical schools.
Okay, thank you. Dr. Bourgeau, if I can turn to you. In a May op-ed in 2021 that you co-authored with CFNU President Linda Silas, you said the following: most Canadians probably don't realize that we lack data on the most basic components of our health workforce. We lack data about the scope of work of healthcare workers, about the diversity of the workforce, such as Indigenous or racial identity and language of service. We don't know how different health teams work together or how they can be recruited, trained, and retained where they are most needed. In some critical sectors, such as home care, long-term care, and mental health care, we don't even know how many workers there are. Now, you've spoken about data being siloed and provinces and territories operating independently. What's the problem with that, with provinces not knowing what's happening in the province next door? And how do you think the national data collection, which you've described, would assist in that?
Thank you for that question. And quoting from the article, I think moving towards pan-Canadian coordination of the collection of data would allow us to plan across different sectors, because we know we're having a conversation about professions, but professions work in sectors. You know, physicians work in palliative care, as my colleagues have noted here. Folks work in long-term care, mental health care. The types of dashboards that they're creating in other OECD countries are looking at this from an interprofessional and sector focus. So that type of data enhancements would really help local decision makers along a variety of different organizations, right? So it's not just the provinces and territories and regions and hospitals, et cetera. So they would want to have access to kind of say, do we have enough? How should we go about planning different models of care? We have no idea. I cannot tell you how many personal support workers there are in Canada. I can't tell you how many addiction counselors there are in Canada. We absolutely need to have that information. Here's the data story. The Canadian Institute of Health Information gets data from a for-profit company for physicians. They don't get it from the medical regulatory authorities. For all of the other professions, they get it from medical regulatory authorities for a select number. The Canadian Institute of Health Information has to negotiate data sharing agreements with dozens of regulatory authorities for the different professions that are regulated. Then they have to collect all of those data, none of which aligns. They have to match that all up. So they spend all of their time negotiating data sharing agreements, and then all of their time trying to make a mountain out of the mess that there is. The data that we have is gender as a binary, male or female, age, and province. You cannot do any health workforce planning with that type of data. So, and we can do better than this. You know, we have an amazing Statistics Canada, agency that collects things nationally on a pan-Canadian basis. What's very interesting about the data from Stats Can is it's based on the national occupational codes, and none of that aligns with regulatory authority data. So just by one example, because I know that the Canadian Occupational Projection System, COPS, has been noted in this committee. COPS suggests that there are 75,000 family physicians in Canada. We know that there are about 45,000 physicians in Canada. So 30,000, an error of 30,000 is pretty remarkable. Federal funds goes into the COPS system. Federal funds goes into a national occupational code that doesn't work at all for health workers. I can't imagine, I'm not a decision maker, but I can't imagine what it must be like making decisions when you have absolutely no tools. The questions that the committee has asked our colleagues here, that should be readily accessible. We should have early warning systems, for unmatched medical graduates, for shortages of personal support workers.
Ms. Bourgeau, this testimony is absolutely fascinating, but well past time. Please wrap up. I know.
I will conclude there.
Okay.
I could speak on this for hours, but I will conclude there.
And you know what? We'd love to listen to it.
Mr. Chair, might I just, if we could remind the witnesses that they're able to put in written submissions, because I think this is really riveting and relevant information, and I think all committee members would benefit from any additional written information that the witnesses may provide.
Mr. Davies is absolutely right. In fact, I've already heard from some members who aren't going to get a chance to ask you questions that they might like to correspond with you, and if the committee is okay with written questions and answers to supplement what's been said today, there clearly is an appetite for that in this room, and heads nodding all around. So, it is absolutely fascinating. It's too bad that we don't have more time, but we do have a little more, and the next person to pose questions is Ms. Goodridge for 5 minutes.
Thank you so much to all of the witnesses for your testimony and for being here with us today. I think I can speak for all members of the committee that the passion you guys have shared, your testimony is definitely important. And Ms. Bourgeau specifically, some of what you were getting at with the data, I think is really succinct. And anything you could provide us in writing to help would be very helpful. I know in my own home province of Alberta, we have, I think they had at one point, AHS had over 1,300 different databases, and not all of them talk to one another, which is kind of ironic for a province that has one unique health system. And so I was just wondering if you could point us in.
Ms. Goodridge, I have to interrupt. The bells are ringing, and the rules require that we get unanimous consent of the committee to continue the meeting while the bells are ringing. Is it the will of the committee to at least have Ms. Goodridge finish her round, if not further? What's the feeling in the room? Okay, so her turn. Okay. So, Ms. Goodridge, go ahead, and you still have your full 5 minutes, and then we're going to wrap it up. Go ahead.
Fantastic. Then I will speak a little bit faster. Do you have any, Ms. Bourgeot or Dr. Bourgeot, do you have any jurisdictions in Canada you could point to that are better with data compared to others?
Thank you for the question. And as a former Albertan and where my family live in rural Alberta, a bit of a shout out to them. I am quite familiar with the data, the richness of data in Alberta, but the inability to align that. One of the things that I will give a shout out to Alberta is that they do have a registry of healthcare aides is what they call them. So that I think is a really promising practice. I think that we could use the opportunity for professions that we don't collect data on right now to move directly towards a pan-Canadian system, as Madame Lefebvre has said in regards to pan-Canadian registration. The other jurisdiction that I will point out that has invested in standardized data across professions has been in Ontario, the creation of the Health Professions Database. And so they have created a minimum data standard. And what that means is, what are the questions that we're going to ask and the data elements that we need? It's insufficient. We have no data in Ontario in terms of Indigenous identity or racial identity, but they do a fairly good job, for example, of ability to provide services in another language. Official languages being critically important in ensuring that people can access services in French and in English. So
fantastic. Because we don't have much time, I'm going to shift gears a little bit. Sorry about that. Again, anything you could provide us in writing would be helpful. Dr. Moineau, when you were talking about how there are so many students that are not placed. Could you point to any jurisdictions that are doing a better job at having placements compared to the rest of the country?
Thank you for the question. So the provinces that have increased that ratio, where there are more residency positions than there are graduates of Canadian medical schools, are doing better. And so I could provide you with that information by jurisdiction. So there are some provinces who really have taken that in consideration and are doing better. The issue is that when we look at this overall in a pan-Canadian way, up until recently, we were still at a ratio of, for each 100 graduates, we had barely, 100 and 101 to 103 positions. And so that's just too tight, but I can certainly provide you with that information.
Fantastic. Thank you. And then I guess to go on to the questions around Paladin, wondering if you guys can point to any provinces that are doing a better job when it comes to palliative care or territories.
Certainly. Thank you very much for the question. So Canada is a patchwork. And in different areas of palliative care, you'll see centers of excellence across the country and many provinces, but also many gaps. Having trained in Alberta, I want to do a shout out for Alberta, because I think in Alberta for a long time, they've done a very good job. I think, and I think we're going to be seeing more coming out of Alberta. In Alberta as well, in terms of supporting hospice care and training for hospices, I would say they're leaders. But again, it's a patchwork. And if you go across the country, some places have got enough palliative care units and palliative care specialists to man them, others haven't. So it really is very variable across the country.
Fantastic. And perhaps you could provide us in writing where those centers of excellence are in different aspects to specific jurisdictions, just to help us with formulating our recommendations.
Will do.
Dr. Moat, do you have anything to add?
I was going to say, I think what we'll do as part of that information is to include some of the work that Pallium is doing with a number of healthcare systems across the country to develop our country's first national palliative care atlas. And this will be an incredible decision-making tool for healthcare leadership and administrators to identify areas of strength and areas of gaps when it comes to palliative care service delivery. So,
well, thank you. And I just very quickly, I know I'm at the end of my time, but I just really want to thank both of you guys for the work you do with palliative care. It's so very important, and not enough is done in that space. So thank you so much.
Thank you.
Thank you, Ms. Goodridge. as per the agreement of the committee, that completes the time that we have for questions. We had asked you for an hour. You waited for an hour, and then you gave us an hour, and we'd like to have a whole lot more. So you may be hearing from some of the members in writing. Thank you very much for being with us, and thanks for your patience. It will be of great assistance to us. Colleagues, if there's one thing that I could ask of you before we adjourn, that is that please send us some more names of witnesses for meetings on the COVID study, because we're running low on that and we need to, yeah. So if you could please do that. And with that, given that the bells are ringing, we are adjourned. Thank you very much, everyone.
Thank you so much.